The data on racial, ethnic, and sexual minorities is actually quite nuanced. What we know based on the data is that if we have, for example, a white identified individual, after controlling for many various factors such as income, educational attainment, and neighborhood, we find that about 1 in 4 white identified individuals are able to seek good health care for a substance use disorder. Unfortunately, when we look at Black and or Latino identified individuals, that number can be as low as 17%, for example. So there's a lot of upstream social determinants that impact an individual's ability to actually seek culturally competent health care. So we know that based on just the literature, that substance use disorders don't happen in a vacuum. They co-occur quite frequently with mental health disorders. And the reasons for this is that oftentimes individuals who aren't able to seek health care for their mental illness actually seek substances as a way to cope with some of these mechanisms, right? So when we think about substance use disorders and prevalence rates, it really does go hand in hand with mental health. Someone has an opioid use disorder, we really do need to connect them to social services, housing, and other resources to make sure that the individual at their core is able to deal with a lot of these stressors that are sometimes out of our control as healthcare professionals. I'm currently based out of Rutgers, New Jersey Medical School, which is in Newark. It's a actually majority Black community with also a big proportion of Portuguese and Hispanic immigrants. So one of the things that we're doing in my school is that we have a low threshold buprenorphine clinic called the Care Center. It's actually a state-funded initiative through which we're actually ensuring that individuals with very complex co-occurring mental health and substance use disorders who have an opioid use disorder are able to seek treatment in our clinic. And so what we see in this clinic is that individuals who come in not only get the care that they need with medication, but they're also able to see counselors, we have social workers, we have referrals, and in the state there's been other pilots that have also increased access to treatment. For example, we've done mobile methadone vans in the state of New Jersey, and this is again another example of how we're going to the community to make sure that we're treating some of these disorders. In the literature, there's been some great examples, specifically in the Southwest, of individuals who treat substance use disorders actually teaming up with clergy members, for example, right? They get involved with clergy members and they train them on how to actually do referrals to substance use disorders. That's somewhere where I potentially want to pilot a program in the Northeast, but there's a lot of great work. I always say that the literature is very rich with data and interventions. We just have to find a way to make it sustainable and make it ongoing, and more importantly, bring it at a national level, which is why APA is a perfect place to talk about some of these initiatives.